السلام عليكم.
وعليكم السلام دكتور.
راح نبدأ إن شاء الله اليوم المحاضرة الثالثة بالبيدياتريك كارديولوجي. بالمحاضرتين السابقتين تكلمنا عن الترانزيشن from beta to neonatal circulations, characteristics of each circulation. قسمنا الcongenital heart disease إلى congenital heart diseases of different types, mainly cyanotic acyanotic. بعدين تكلمنا عن acyanotic، قسمناهم إلى two subgroups: obstructive lesions like pulmonary stenosis, aortic stenosis, coarctation, and left to right shunts like ASD, VSD, endocardial cushion defect, and patent ductus arteriosus. Today we'll continue and speak about the cyanotic groups. In fact, the cyanotic groups are many and much more complex in their pathology, pathophysiology, presentation, diagnosis, and management, in comparison with the acyanotic groups. But the most important to you as undergraduate students are tetralogy of fallute and transposition of great arteries. That's why I speak exclusively about these two categories, so that you will be oriented and you will not be confused with the multiple and different complex cyanotic congenital heart diseases. You remember we said that the cyanotic groups of congenital heart disease can be broadly classified into a group characterized by decreased pulmonary blood flow and another group characterized by increased pulmonary blood flow. The main type that's associated with decreased pulmonary blood flow is the tetralogy of fallute. Tetralogy of fallute is considered as the commonest cyanotic congenital heart disease and accounting for 10% of all types of congenital heart defects. Anatomically speaking, if you look at this picture, you've got four abnormalities that it is called tetralogy. You know, the word tetra by Latin language means four. So it's called tetralogy because there are four anomalies. First, there is ventricular septal defect, as you see in this picture. Number two, there is pulmonary stenosis. It could be subvalvular, valvular, supravalvular, but usually it is subvalvular, or we call it infundibular in most of the cases. And there is overriding of the aorta. You see, this is the aortic root from this point to this point, and there is malalignment of the VSD so that the aortic root is overriding the interventricular septum, and blood from both right ventricle and left ventricle enters into the aorta. And this is the meaning of overriding of aorta. It overrides the interventricular septum. And also there is hypertrophy of the right ventricle, we call it RVH. The VSD is usually large VSD. And the main determinant of the pathology and pathophysiology of tetralogy of fallute is the degree of pulmonary stenosis. The more the severe the pulmonary stenosis, the more the severe the cyanosis, the more the severe the disease, and the earlier the presentation of the disease. Clinically, regarding the symptoms, cyanosis is the cardinal feature and should be present at birth or shortly thereafter, by the age of 1 to 3 months. Exertional dyspnea also is common presenting finding. And also we got squatting or hypoxic spills. What I mean by squatting? Squatting is this position of the child. While the child is playing, he got dyspnea and an increasing cyanosis, and then he takes this position to get relief from the shortness of breath, hypoxia, and cyanosis. Hypoxic spills, I'll speak about them the next slide. So these are the first three symptoms. Occasionally, there might be a type of cough called acyanotic cough. This is rare and don't focus on it. Majority of the coughs are those with cyanosis. This one with acyanosis or mild cyanosis are rare and don't take them in consideration because the degree of the pulmonary stenosis is mild. Even there might be left to right shunt. Sometimes, on the opposite hand, sometimes the cyanosis is very severe and it is present at birth or shortly after birth. And this might be associated with even pulmonary atresia. For the hypoxic spills that I told you about, it is one of the paroxysmal presentations of tetralogy of Fallot. During the spill, the child becomes irritable, agitated, cyanosed, and crying excessively, and dyspneic. And the murmur on auscultation decreases in intensity. In fact, this happens because of the increasing severity of the infundibular stenosis and an increasing right to left shunt, making the hypoxia more severe. And even in such attacks, the child may become unconscious. He may develop convulsions, hemiparesis, or even death. Other mode of presentation of tetralogy of Fallot is thromboembolism. And this happens because of polycythemia and also because of the paradoxical embolization. Cerebral abscess also may be formed in tough patients, and this happens also due to right to left intracardiac shunt. Because normally, you know, the right side of the blood undergoes some sort of sterilization by the macrophages in the lungs. And because there's right to left shunt, the blood, before being exposed to the macrophages of the lungs, it passes from the right ventricle to the left ventricle. And then, if there is some sort of infective microorganisms, they will find their way to settle down in the brain and make brain abscess. Treatment of spills that I spoke about first include placement of the child in knee-chest position, making the knees just in touch with the chest as much as possible. The idea behind this position is to increase the peripheral vascular resistance. And when this happens, when the peripheral vascular resistance increases, the right to left shunt will decrease because the left side of the pressure will become higher. So the right to left shunt will decrease and the cyanosis and hypoxia will decrease. And you should avoid taking any sampling of blood during the attacks of spills because this causes the baby become more agitated and this produces a negative effect. So advise the mother to place the child in this position or in the bed in this position. Better in this position, it's more comfortable to the baby. This will decrease the cyanosis. Second line of treatment of hypoxic spills or TET spills is the oxygen administration. Third, subcutaneous morphine because it causes infundibular relaxation and sedation to the child in a dose not more than 0.2 milligram per kg subcutaneously. And also beta-adrenergic blockers, example, propranolol in a dose of 0.1 to 0.2 milligram per kg intravenously slowly. Also propranolol as a beta blocker causes relaxation of the infundibular area and increases the pulmonary blood flow, decreases the right to left shunt. On physical examination of a child with long-standing growth retardation and developmental delay will be apparent, and this is especially true for children with severe hypoxia when the oxygen saturation is less than 70%. In adolescent children, you may notice also there is developmental delay. For example, in girls, they don't develop secondary sexual characters, and for boys the same. Also, during general examination, you find varying degrees of cyanosis, tachypnea, rubbings of fingers. The pulse and the blood pressure are usually normal in children with tetralogy of Fallot. Local examination of the chest may reveal precordial bulging due to the right ventricular hypertrophy. And you may feel a systolic throat on the left along the sternal border. This is due to the pulmonary stenosis. And the murmur is usually loud, systolic, and most intense at the left sternal border. Again, it is due to pulmonary stenosis. And generally, it is ejection inequality, that is to say mid-systolic. When we say ejection systolic, it means mid-systolic. But it may sound sometimes hollow systolic, tending from S1 to S2. And here, it will be here at the left lower sternal border, and it will be due to VSD. By investigations, the classical chest X-ray finding in some patients of TOF is boot-shaped heart. It is not always seen, but it might be seen. And in children with long-standing TOF, characterized by upturned apex of the heart, which happens due to right ventricular hypertrophy. And an important thing is the oligemic lungs. Oligemic lungs, it means lungs with decreased pulmonary vascular markings. The cause is clear for that because there is pulmonary stenosis and little blood is going to the lungs. So the lungs appear oligemic, more black than the normal, less pulmonary vascular markings are seen. So we call it oligemic. And the opposite, if the lung markings are very evident, it is called plethoric lung. By ECG, of course, you are going to see right axis deviation, as you see, and lead 1 and lead 3, the main QRS complex are reaching each other. That's right axis deviation. Right ventricular hypertrophy characterized by prominent R in V1 and deepest in V6. By echo, which is the main tool for the diagnosis, you can see the VSD here. You can see the aortic overriding. This is the aortic root from this point to this point, and this is the aortic valve. And this is the interventricular septum. This is the LV cavity. This is the RV cavity. This is the left atrium. This is the mitral valve. And this is the aorta. You can see that the aorta is overriding the interventricular septum. And there is a VSD extending from this point to this point. There is a RVH. And pulmonary stenosis is not shown by this picture. And you can determine the degree of the pulmonary stenosis, the presence of associated problems, in addition to the findings of TEP. Sometimes we need angio, cardiac catheterization and angiography for patients with TEP, especially preoperatively. Before doing operations, some surgeons ask for cardiac catheterization and angiography of TEP patients. And the pediatric cardiologist will do it, confirm the findings for the cardiac surgeon. Or even sometimes the pediatric cardiologist need it if the echo findings are not so clear and not enough. Here, a catheter is coming from the jugular vein on the superior vena cava to right atrium and the right ventricle. And then there is a contrast media is injected in the right ventricle. Part of the contrast media passes through the VSD. VSD extends from here to here. And the contrast media passed from the right ventricle to the left ventricle, is posteriorly located. This is the infundibular stenosis. And here is the valvular area. You can see there's infundibular and valvular stenosis. And this is the area below the valve, which is called infundibular chamber. It's a little bit dilated or maybe normal. But there is some sort of fundibular stenosis and valvular stenosis. Natural history and complications. In other words, what happened to TEP patients if they are left untreated? Cyanosis would worsen with the time, and there will be development of iron deficiency anemia, in spite of the presence of polycythemia. Polycythemia due to hypoxia means an increased number of red blood cells. But in spite of the high number of these red blood cells, the amount of the iron which is present in these red blood cells is less than the normal. So we call it relative iron deficiency anemia. Growth retardation will continue. Hypoxic spells may happen. Brain abscess. SBE, subacute bacterial endocarditis, occasionally is a complication. Coagulopathy due to polycythemia also can be a problem. So this is a natural history of patient with tetralogy failure, if left untreated. Usually patients with tetralogy failure, if not exposed to life-threatening complication like SPE or brain abscess or thromboembolism of the brain, they may survive until the age of 40 years. But usually they develop these complications during life as they don't reach such ages. They may die by the teenage or early 20s. Treatment includes surgical correction, including closure of the VSD and widening of the narrowed area, whether it is subvalvular, valvular, or supravalvular, and everything will return to normal. The usual age of the corrective surgery is something around 6 months of life. But the problem is that sometimes you've got a newborn babies who are very young and they have severe cyanosis and need some sort of intervention. Tough correction in such age groups is difficult. So we do some sort of palliative surgery. Palliative means تلطيفية بالعربي يعني جراحة مؤقتة تلطيفية to decrease the cyanosis, like modified Blalock Tausig shunt. Modified Blalock Tausig shunt. We call it BT shunt. BT shunt. Because the original Blalock Tausig shunt involved cutting the left subclavian artery and connecting it to the left pulmonary artery so that the lungs receive blood from the subclavian artery. Of course, the blood in the subclavian artery, it is mixed blood, not a pure oxygenated, not deoxygenated, because there is intracardiac shunting. And the lungs will receive mixed blood. It will oxygenate it and return it to the heart as oxygenated blood. And here, after cutting the subclavian artery, collaterals will develop and give a blood supply to the upper limb, left upper limb. This is the original Blalock Tausig shunt. It's no longer now used. Now they are using modified Blalock Tausig shunt in the right side rather than in the left side, and involves a tube connection between the right subclavian artery and right pulmonary artery, because the access to the right pulmonary artery and right subclavian artery is easier than the left side. So they are doing it in the right side, and it's called modified Blalock Tausig shunt or modified BT shunt. It is written here BT shunt. So once one tells you BT shunt, it means Blalock Tausig shunt. The other type of cyanotic congenital heart disease is that which is associated with increased pulmonary blood flow. And the best example of this is the detransposition of the great arteries. I said detransposition of the great arteries because we got ill transposition of the great arteries and other types of transpositions. It is not of importance to you because they are rare and complex. The simplest one and the commonest one is the detransposition of the great arteries. TGA represent about 5% of all congenital heart defects, and it is considered as the commonest cyanotic congenital heart disease that is present in the neonatal period. When you got a newborn baby with cyanosis, especially if it is severe, it is likely to go TGA rather than TOF, because the cyanosis of TOF sometimes delayed until the age of 1 month or 2 months. But TGA is characterized by early development of cyanosis. In TGA, there is ventriculoarterial discordance. Normally, aorta arises from the left ventricle, and pulmonary artery arises from the right ventricle. And this is called ventriculoarterial concordance. It means the pulmonary artery arises from the right ventricle. The aorta arises from the left ventricle. And here it is called concordance. The ventriculoarterial concordance. If the opposite happens, like what is seen in TGA, It is called discordance. So, in transposition of the great arteries, there is ventriculo-arterial discordance because the aorta arises from the right side and the pulmonary artery arises from the left side. Of course, if there is no mixing of blood, I mean mixing of the deoxygenated with the oxygenated blood at ventricular level by VSD or at arterial level by ASD or at arterial level by PDA, there is no any mixing of blood between the two circulations at any one of these levels. This condition is incompatible with life. And the baby will not live for more than a few hours because there will be two parallel circulations. Imagine that. This is the right ventricle and it contains deoxygenated blood. If there is no mixing of the two bloods, it will go, this deoxygenated blood will go through the aorta and then it will be pumped to the body and from the as deoxygenated blood, and then it will return back through the venous system to the right atrium. Again, it will be pumped by the aorta from the right ventricle to the body. So there is a continuous circulation of deoxygenated blood. In the opposite side, the oxygenated blood in the left ventricle will be pumped to the pulmonary artery, to the lungs, to the pulmonary veins, to the left atrium, to the left ventricle, to the pulmonary artery again. And it will continue as single circulation of oxygenated blood. So there will be two parallel circulations rather than two continuous circulations, because in normal human being there is two continuous circulations. One complete the other. But in TGA, if there is no mixing of blood by VSD, ISD, or PDA, there will be two parallel circulations, which is incompatible with lives. Clinical manifestations. Cyanosis is present at birth and is always present. There is no TGA without cyanosis. There might be symptoms of congestive heart failure, like dyspnea, feeding difficulties, and they may develop even in the neonatal period. And on examination, in addition to cyanosis and respiratory difficulties, you may hear a murmur of VSD, PDA, if they are present, or even of RVOT or LVOT obstruction. Sometimes TGA is associated with pulmonary stenosis, or it might be associated with aortic stenosis, which may also give us a murmur. But TGA by itself doesn't produce murmur. If there is murmur, it means there is an additional problem, like VSD, PDA, pulmonary stenosis, or aortic stenosis. There might be features of heart failure, which will be discussed later on. On chest X-ray, again, TGA is characterized by characteristic chest X-ray finding called egg on side. Egg on side. You see the heart looks like an egg, which is lying on its side. Egg on side. And the important thing, there will be euphoric lungs, because TGA is characterized by increased pulmonary blood flow, so there will be plethoric lungs. Unless, of course, there is severe pulmonary stenosis. If there is TGA plus severe pulmonary stenosis, in this case, the lung feels also like pyrolygemic, like in TOF. The ECG will also again show RVH and right axis deviation like what is seen in TOF. So one may ask you a question, what is the difference between TOF and TGA by chest X-ray and ECG. By chest X-ray and TOF there are oligemic lung fields. In TOF there is oligemic lung fields, while in TGA there are plethoric lung fields. The heart may show boot shape appearance in TOF. It may show egg-on-side appearance in PGA. By ECG, both of them show right ventricular hypertrophy and right axis deviation. Echo is the most sensitive and powerful tool for the diagnosis of PGA. Normally, we can see the left ventricle like that, right ventricle like that, and we can see that there is a vessel taking off from the left ventricle and then divides into two branches, right and left branches, which is pulmonary artery. Normally, we don't get such a picture. You see, this is a vessel that takes off from the left ventricle, and this vessel here, this black one, divides into this branch, which is left pulmonary artery, and into this branch, which is right pulmonary artery. While the right ventricle gives rise to a single vessel, which is not dividing, which is the aorta. And there is also VSD, ASD, other lesions all can be diagnosed by it. Treatment of TGA, first, if it is diagnosed in the first few hours of life, or 1 day of life, we have to give prostaglandin E1 infusion. And you know the benefit of prostaglandin E1 infusion from the last lecture. I told you it keeps the ductus arteriosus patent. If the ductus arteriosus remain patent, there will be mixing between the pulmonary and systemic circulations, which is of good effect on the baby. But if the infant remains significantly hypoxic, in spite of the presence of the PDA, which appears to be not sufficient, in this case, we have to create ASD for this baby. We are performing atrial septal defect by a procedure called balloon atrial septostomy. Originally, it has been described by a doctor called Rashkin, and the procedure is named according to his name, called Rashkin balloon atrial septostomy. Nowadays, we call it balloon atrial septostomy because there is some modifications of Rashkin balloon atrial septostomy. Generally, the principle is the same. We introduce the balloon to the patent foramen ovale from the right atrium into the left atrium. This is, of course, done by the pediatric cardiologist. Anything involving catheters, balloons, occluders is the job of the pediatric cardiologist, not the surgeon. The balloon is inflated in the right atrium, and then taking out of the left atrium into the right atrium rapidly and forcibly, making tear to the interatrial septum and creating an atrial septal defect. And you know, as I told you in the beginning of PGA, it is incompatible with survival unless there is mixing. The presence of any mixing between the two circulations is of useful effect to the child. And then, during corrective surgery, this ASD will be closed. The corrective surgery that is done for TGA is called arterial switch operation. Arterial means aorta and pulmonary. Switch, it means changing their position. Arterial switch operation. We've got another operation called arterial switch operation that I'm going to tell you. You see the stages of the operation here. This is a DTGA, the aorta with cyanotic, with deoxygenated blood originating from the right ventricle, while the pulmonary is originating from the left ventricle, and then PDA. It involves returning the pulmonary artery to the right side. It's cut from its root and returns back to the right ventricle, and the aorta also cut from its root and returns back to the left ventricle. And also, the PDA is going to be ligated, and the arterial septal defect also it will be sutured and used. And this is called arterial switch operation or Gitane operation. The problem for this operation is that it should be done in the first few weeks of life, best in the first 2 weeks of life. Why? Because if you leave the patient for months, the right ventricle will become severely dilated, and the heart becomes affected by this abnormal circulation, and the coronary arteries at the same time cannot be manipulated. So the surgery of arterial switch operation cannot be performed. So we are in a hurry for a child with PGA if we are deciding that he needs arterial switch operation. What happens if the child comes later on, or we cannot do arterial switch operation for him? We do another type of surgery called arterial, not arterial, arterial switch operation. And in this case, we keep the aorta arising from the right ventricle and the pulmonary artery from the left ventricle. We don't interfere with this abnormal anatomy. We are creating another type of anatomy that diverts the systemic venous return of superior vena cava and inferior vena cava via a baffle to the right, to the left atrium. So the systemic venous return, and instead of emptying into the right atrium, we divert its drainage to the left atrium. And the pulmonary arteries, instead of draining to the left atrium, we divert their drainage to the right atrium. So in this situation, the right side of the heart will be the systemic side, while the left side of the heart will be the pulmonic side. And of course, this is of benefit to the patient, but it is not useful like arterial switch operation, because in arterial switch operation, nearly you are returning to the normal anatomy and normal physiology. Here, it is modification to the normal anatomy and normal physiology. هسه خلصت المحاضرة of cyanotic congenital heart disease. If you got any question, I am ready to answer. If any student has any question, please just raise his hand and we can answer his question. صور نائل عبد الرزاق رفع ايده. خلي تفضل. نعم. الوول اوف وات؟ ما فهمت عليك. هاي الارتيريال. الارتيريال سويتش هي هاي الارتيريال سويتش. رجعنا الايورتا بس من هنا ينقص من هاي النقطة. تشوف النقطة اللي أدشر عليها؟ من هنا ينقص الايورتا ويتحول من الرايت سايد على الليفت سايد على مكانه الحقيقي، والبلمونري ينقص من هاي النقطة أيضا ويتحول على مكانه الحقيقي. السؤال مالتك شنو هو؟ يتحمل له نفس الفصل. احنا ما راح نجيب فصل جديد من عندنا، يعني راح نقصه من الجذر مالته، راح نقص الايورتا من الجذر مالته ونرجعه على مكانه الطبيعي. وبالبلمونري نقص البلمونري ارتري من الجذر مالته ونرجعه على مكانه الطبيعي، يتحمل ماكو اشكال. طبعا يعني الموضوع به تفاصيل اخرى، انه later on what happens, of course there may be يعني this area of reconstruction may become stenosed, the valves may become diseased later on, like pulmonary stenosis, like aortic valve regurgitation, and there are some more details about this condition. I don't want to bother you with these things. If you know this, just arterial switch, arterial switch, and arterial switch is done in the first few weeks of life. Arterial switch done later on and involve diversion of venous return. And that's enough. It's okay for you. لأنه incidence of infective endocarditis with acyanotic congenital heart disease, it is negligible. It is very minimal with acyanotic congenital heart disease. For example, with ASD or VSD or pulmonary stenosis, etc., PDA, they find that the incidence of infective endocarditis after dental procedures, for example, is negligible. And even the risk of the bacterial flora that's present in the mouth is higher than that which is associated with the surgeries. And such patients, they don't develop any sort of infective endocarditis. So on long term, with the studies, with follow-up, and by guidelines, they found that the incidence of infective endocarditis with acyanotic congenital heart disease is nearly none. So they don't advocate for SBA prophylaxis. On the opposite, for patients with cyanotic congenital heart disease, the risk is high